Good morning, and welcome back. I want to start today with a number that most of you have heard your entire adult life. 120/80. If you've been to a doctor's office even once in the last few decades, you've heard this number repeated as the gold standard, the target, the number you're supposed to be chasing down as low as possible. For years, that's exactly what patients were told, and in many cases, what doctors themselves believed without much room for nuance. But here's what I want to walk you through today, carefully and honestly, because this is a genuinely important shift happening in medicine right now. The conversation around ideal blood pressure for older adults has been changing, and it's been changing based on real clinical research, not guesswork. And the changes aren't as simple as lower is always better or higher is fine. The real picture is more nuanced than either extreme, and I think you deserve to understand it clearly, so that you can have a genuinely informed conversation with your own doctor about what target actually makes sense for you specifically. Before I go any further, I want to say something important, and I'm going to repeat it more than once during this video because it matters that much. Nothing in this video is telling you to change your blood pressure medication, adjust your dose, or stop taking anything you've been prescribed. Blood pressure management is deeply individual, and what's right for one person over 65 may be completely wrong for another person the same age with a different health history. What I want to give you today is the background and the real research driving this conversation, so that when you sit down with your doctor, you can ask sharper, more specific questions, rather than just accepting a single number without understanding where it came from or whether it still applies to you. Let's start with where the old standard came from, because understanding that history actually helps explain why things are shifting now. Where 120/80 came from, and why it became the default for everyone. For a long time, the general target used across most adult patients, regardless of age, was based on the idea that lower blood pressure consistently meant lower risk of heart attack, stroke, and other cardiovascular events. And broadly speaking, that relationship is real. Elevated blood pressure over time absolutely does increase the risk of these events. That part of the science isn't in question, and it hasn't changed. What has changed is a more specific question that took longer to get properly researched: is the relationship between blood pressure and health outcomes the same in a 35-year-old as it is in an 80-year-old? For a long time, doctors applied largely the same target across almost all adult age groups, because there wasn't yet enough dedicated research specifically studying more aggressive blood pressure targets in older populations, especially older populations with multiple other health conditions, which is an extremely common and realistic situation for a lot of people over 65. That began to shift significantly with a large, well-known clinical trial called the SPRINT trial, short for the Systolic Blood Pressure Intervention Trial, a major study funded by the National Institutes of Health. This trial specifically compared a more intensive blood pressure target, aiming for a systolic pressure, that's the top number, below 120, against a standard target of below 140, in adults over 50, including a substantial number of participants over 75. The trial found that the more intensive target was associated with a meaningfully lower rate of cardiovascular events and death in that population. This was a genuinely important finding, and it contributed directly to updated guidelines from major medical organizations, including the American College of Cardiology and the American Heart Association, which moved toward recommending a lower target, generally below 130/80, for many adults, including many older adults. So on one hand, you have real research supporting a more aggressive target for reducing cardiovascular risk. That's not something being quietly walked back. But here's where the nuance comes in, and this is the part that doesn't always make it into a 15-minute appointment. Why lower is always better doesn't apply the same way to every senior. The SPRINT trial, while genuinely important, specifically excluded certain groups of people from participating. It excluded people with diabetes. It excluded people who had already had a stroke. And notably, it excluded people living in nursing homes and people considered to have significant frailty. This matters enormously, because a large number of adults over 75, and especially adults over 80, do fall into one or more of these categories, meaning the specific population that trials studied doesn't perfectly represent every senior sitting in a doctor's waiting room today. Here's the concern that geriatric specialists have raised, and it's a legitimate, well-documented one. As we age, our blood vessels naturally become somewhat stiffer, and our body's ability to regulate blood pressure quickly, especially when standing up from sitting or lying down, becomes less efficient. This can lead to something called orthostatic hypotension, a sudden drop in blood pressure when changing position, which can cause dizziness, lightheadedness, and in some cases, falls. And falls in older adults are not a minor concern. They're one of the leading causes of serious injury and loss of independence in this age group. If blood pressure is pushed aggressively lower through medication, particularly in someone who is already frail, has multiple health conditions, or is on several other medications, the risk of these sudden drops in blood pressure, and the falls that can result from them, becomes a real and documented concern. There's also a separate consideration around cognitive function. Some research has raised questions about whether blood pressure that's pushed too low in certain older adults, particularly those who are frail, might affect blood flow to the brain in ways that aren't fully beneficial, though this remains an area of ongoing research rather than a fully settled conclusion. Because of these considerations, more recent geriatric-focused guidance has moved toward a more individualized approach, rather than a single blanket number applied to every person over a certain age. For a healthy, active 68-year-old with no other major health conditions, a lower target, generally in line with the newer guidelines, often does make sense and is often the appropriate goal. But for an 84-year-old managing multiple health conditions, dealing with some frailty, or with a history of falls, many geriatric specialists now advocate for a somewhat less aggressive target, prioritizing stability and quality of life alongside cardiovascular risk reduction, rather than chasing the lowest possible number regardless of the trade-offs. The specific numbers being discussed, and why context matters more than the number itself. Let me walk through this a bit more specifically, because I think the actual numbers help make this concrete rather than abstract. The more intensive target that came out of the SPRINT trial and subsequent guideline updates is generally a systolic blood pressure below 130, sometimes described as below 130/80. This is now a commonly cited goal for many adults, including many otherwise healthy older adults. However, for older adults who are more frail, who have limited life expectancy due to other serious illnesses, or for whom the burden of additional medication and its side effects may outweigh the cardiovascular benefit, some geriatric guidelines suggest a somewhat more relaxed target, in the range of below 150, may be more appropriate, prioritizing avoiding the harms of overtreatment, like dizziness, falls, and medication side effects, over strictly chasing the lowest number possible. It's also worth mentioning that different professional organizations, both in the United States and internationally, don't all state the exact same numbers. The European Society of Cardiology and European Society of Hypertension, for example, have published their own guidance that overlaps substantially with American guidelines but isn't worded identically in every detail, particularly around how aggressively to treat blood pressure in adults over 80. This isn't a sign of disagreement or controversy in the sense of anyone being simply wrong. It reflects the fact that guideline committees are making careful judgment calls about how to weigh benefit against risk across a very broad and varied population, and reasonable, evidence-based groups can land on slightly different specific thresholds while agreeing on the same underlying principles. This is genuinely why I keep saying this isn't a simple story of the number is changing for everyone. It's more accurate to say that medicine has moved away from a single universal number for all older adults, and toward a more individualized conversation that takes into account a person's overall health, frailty level, other medical conditions, and personal priorities. Two people who are both 78 years old, on paper, might reasonably have two different blood pressure targets, and both targets could be entirely correct, because they're based on two different overall health pictures. How your blood pressure is actually measured matters more than people realize. Before we go further, I want to spend a moment on something that doesn't get enough attention, because it directly affects whether the number your doctor is working with is even accurate in the first place. There's a well-documented phenomenon called white coat hypertension, where a person's blood pressure reads higher in a clinical setting, sitting in an exam room, often after rushing to get there, than it does in their everyday environment at home. There's also the reverse situation, called masked hypertension, where blood pressure reads normal in the office but is actually elevated at home, often because a person is more relaxed during a brief clinical visit than they are during the ordinary stresses of daily life. Both of these situations can lead to a mismatch between the number your doctor is using to guide treatment decisions and what your blood pressure actually looks like most of the time. This is one of the reasons many doctors now recommend home blood pressure monitoring as a genuinely valuable tool, not as a replacement for clinical visits, but as a way of getting a more complete and accurate picture over time. If you do monitor your blood pressure at home, there are a few things worth doing correctly to get an accurate reading. Sit quietly for about 5 minutes beforehand, keep your feet flat on the floor and your arms supported at heart level, avoid caffeine or exercise in the 30 minutes before measuring, and take 2 or 3 readings a minute or so apart rather than relying on a single number. A log of consistent home readings over a week or two can give your doctor a far more reliable picture than a single reading taken during a 15-minute appointment, and it's genuinely one of the most useful things you can bring to a conversation about whether your current target and treatment plan still make sense. Why this conversation often doesn't happen clearly in a regular appointment. I want to be honest about why this nuance sometimes gets lost. A standard appointment is often 15 to 20 minutes long, and a lot of that time gets used up on immediate concerns, medication refills, and other pressing issues. Explaining the full context behind a blood pressure target, the history of the guidelines, the trade-offs involved, and how they apply specifically to your situation, takes real time, and it's easy for that nuance to get compressed into simply being told a single target number without much explanation of the reasoning behind it. There's also the reality that guidelines themselves have shifted more than once over the past couple of decades, which can understandably create some confusion, both for patients and, frankly, for some providers trying to stay current with the latest recommendations. This isn't a sign of doctors doing anything wrong. It reflects the genuinely evolving nature of medical research, which is a good thing overall, but it does mean patients benefit from asking specific questions rather than assuming the number they were given years ago is still the most appropriate one for their current situation. There's one more factor worth naming honestly, which is polypharmacy, the situation where a person is taking several medications at once, often prescribed by different doctors for different conditions, without any single provider necessarily having a complete view of how everything interacts together. Blood pressure medications are a common part of this picture for many older adults, and it's entirely possible for a combination of medications, each individually reasonable, to add up to more blood pressure lowering than anyone specifically intended. This is exactly the kind of situation where a pharmacist, reviewing your complete medication list, can add real value alongside your primary doctor. What questions to actually bring to your doctor? So here's where I want to make this practical and genuinely useful for you. The next time you're in for a blood pressure check, or your next general appointment, here are some specific questions worth asking, written in a way that invites a real conversation rather than a quick answer. First, ask your doctor directly, based on my current health and any other conditions I have, what blood pressure target are we aiming for, and why is that the right target specifically for me? This shifts the conversation away from a generic number and toward your specific situation. Second, ask, have I ever experienced dizziness or lightheadedness, especially when standing up quickly? And if so, could that be related to my current blood pressure medication or target? This is directly relevant to the fall risk concern we discussed earlier, and it's a genuinely important symptom to flag if you've experienced it, even occasionally, even if it seemed minor at the time. Third, if you're on multiple blood pressure medications, or several medications in general, ask, is there a chance that the combination of my current medications is pushing my blood pressure lower than what's actually appropriate for me at this stage? This invites your doctor to look at the full picture rather than just the most recent single reading. Fourth, especially if you're managing several other health conditions or have noticed increased frailty over the past year or two, ask, given everything else going on with my health, does it still make sense to aim for the more intensive blood pressure target? Or would a somewhat less aggressive target be more appropriate for me right now? This is a completely reasonable, legitimate question, and a good doctor will take it seriously and walk through the reasoning with you rather than brushing it aside. Fifth, ask about how your blood pressure is actually being measured and tracked. Would it be helpful for me to monitor my blood pressure at home and bring in a log of readings, rather than relying only on the number we get during this appointment? Given what we just discussed about white coat effects and masked hypertension, this is a genuinely useful question that many doctors will welcome. And finally, if you're someone managing your blood pressure primarily through medication, it's worth asking what role lifestyle factors, things like sodium intake, physical activity, weight management, and stress, might play in your specific situation, and whether there's room to work on those alongside, or in addition to, your current medication approach. For some people, meaningful lifestyle changes can allow for a lower medication dose over time, under a doctor's supervision, which reduces both cost and potential side effect burden. A brief word on lifestyle factors, since they're part of this same picture. While medication is often a necessary and appropriate part of blood pressure management, especially as we age, it's worth acknowledging that several everyday factors do have a well-established relationship with blood pressure, and they're worth discussing with your doctor as part of the bigger picture, not as a replacement for medication, but as a genuine complement to it. Sodium intake is one of the most well-studied of these, and many people are surprised by how much sodium is present in processed and restaurant foods, even ones that don't taste particularly salty. Regular physical activity, even moderate activity like consistent walking, has real, well-documented effects on blood pressure over time. Sleep quality and stress management also play a documented role. None of these factors replace medication when medication is genuinely needed, but they're a meaningful part of the conversation your doctor can help you think through, particularly if you're hoping to explore whether a lower medication dose might become appropriate over time. Bringing this together. So let's pull this back together. The idea that there's a single blood pressure number that applies equally to every person over 60 was never entirely accurate, and it's become even less accurate as more dedicated research has focused specifically on older populations. Some of the most important guideline updates in recent years, driven by trials like SPRINT, have actually pushed many adults, including many healthy older adults, toward a lower, more intensive target than what used to be standard. At the same time, geriatric medicine has developed a more careful, individualized approach for older adults who are more frail or managing multiple conditions, recognizing that the risks of overtreatment, dizziness, falls, and medication burden need to be weighed seriously alongside the benefits of lower blood pressure. This isn't a story about doctors hiding something from patients. It's a story about medicine becoming more precise and more individualized over time, which is generally a good thing, but which also means the old approach of simply handing someone a single number without much explanation is genuinely outdated. You deserve to understand not just what your target is, but why that specific target was chosen for you, and whether it's been re-evaluated recently in light of any changes in your overall health. Here's a simple, concrete step you can take before your next appointment. Consider picking up a home blood pressure monitor if you don't already have one, and take readings consistently over a week or two, following the proper technique we discussed, sitting quietly beforehand, feet flat, arms supported at heart level. Write down your readings, along with any episodes of dizziness or lightheadedness you've noticed, even minor ones. Bring that information with you, and ask your doctor directly whether your current targets still make sense given your overall health picture today. That single conversation, backed by real data about your own body rather than a single office reading, can meaningfully clarify whether you're on the right track, or whether an adjustment, made carefully and under medical guidance, might actually serve you better. If today's video helped you understand this topic more clearly, I genuinely appreciate you sharing it with someone in your life managing blood pressure concerns, particularly if that's an aging parent or a spouse navigating this same conversation with their own doctor. And if you haven't already, consider subscribing.